Hello, everybody. We're so glad to see all of you online for this webinar. We'll be talking today about new research on patient acceptability of social risk screening. This is research that has been conducted over the past year or so by a multi-site group of researchers, and it has not yet been published. We're very excited to be sharing these results with you today. I am Caroline Fichtenberg, the Managing Director of the Social Interventions Research and Evaluation Network at the University of California, San Francisco, also known as SIREN. For those of you who are wondering, we are recording this webinar and we'll send you the link as soon as it is available. If you have any questions or any technical issues, please submit them via the chat function. You are all on mute, and so any questions need to be submitted via the chat function in the lower left-hand side of your screen. Before getting started with the presentation, I want to just take a moment to introduce the Social Interventions Research and Evaluation Network to those of you who are not familiar with it. We are an initiative housed at the University of California, San Francisco, and our mission is to catalyze and disseminate high-quality research that advances healthcare sector efforts to improve health equity by addressing social risks. We help catalyze and conduct high-quality research. We collect and disseminate research findings, and we provide evaluation, research, and analytics consultation services. At the bottom of this slide, you can see our website address, as well as our email address, as well as our Twitter handle. There are two resources I want to highlight briefly that if you are not familiar with, you may want to explore. We have an evidence library on our website that collates in one place all of the research, both peer-reviewed and non-peer-reviewed, on interventions to address social risks as part of health care. And we highly encourage you to go look at it. If you are looking for any research in this area, you can search for it based on the type of study design, the social determinant of health, the population, outcomes, whether it's focused specifically on screening, as well as do a text search. The other resource I want to highlight is our monthly newsletter, where we send out every month the new research that has been published over the previous month, as well as events, other information, funding, training, and job opportunities that may be of interest if you're interested in social needs interventions in healthcare. Before going further in the webinar, I just want to acknowledge that this webinar is funded through a Patient-Centered Outcomes Research Institute, PCORI, Eugene, Washington Engagement Award. And the views presented in this webinar are solely the responsibility of the presenters and don't represent the views of PCORI. Again, for those of us who may just be joining us, we are recording this webinar, and the recording and slides will be available on our website next week, and we'll email all of you about it once it's up. Also submit any questions and technical issues via the chat function. Great. Now, without further ado, I want to introduce our two speakers today. We will be hearing from Amelia DeMarcus, who is a primary care research fellow in the Department of Family and Community Medicine at the University of California, San Francisco, and who has been working closely with the SIREN UCSF team. And we'll also be hearing from Elena Byhoff, who is an assistant professor in the Department of Medicine and with the Institute for Clinical Research and Health Policy Studies at Tufts Medical Center in Boston. And again, for those of you who are just joining, this is Caroline Fichtenberg speaking from SIREN at UCSF. Great. I want to now hand it over to Amelia to share the results of this study.
Wonderful. Thank you so much, Caroline, for that introduction. Today, as Caroline mentioned, we'll be talking about the acceptability of social risk screening to patients and caregivers at diverse healthcare settings. We have nothing to disclose. I do want to acknowledge our primary funder, the Commonwealth Fund, in addition to SIREN for supporting this work. I had additional support from the UCSF Primary Care Research Fellowship, and Elena was funded by an NIH K-12. I'm going to start by giving you some background about how this research originated. We know that social risks, including socioeconomic factors, one's physical environment, greatly impact a person's health. Amidst mounting evidence of the impact of social risk factors to health, there's been a policy push to integrate social risk screening into healthcare. While there's been some research on social risk screening, much is focused on provider and staff perspectives, and patient attitudes towards social risk screening has predominantly focused on single domains such as food insecurity screening and limited to single clinical sites and predominantly taken place in pediatric patient populations. With all the excitement around social risk screening, we wanted to explore patient acceptability in diverse healthcare settings. You may be aware that in 2017, the Center for Medicare/Medicaid Innovation published a 10-item screening tool as part of its Accountable Health Communities demonstration project. The program requires screening for 5 socioeconomic actionable domains, which include housing, both the stability and quality, transportation, medical and non-medical, utilities, food security, and personal safety. While some of the individual screening questions came from independently validated screening tools, such as the Hunger Vital Signs, there was not any formal research done on the comprehensive tool other than unpublished cognitive testing conducted with about 30 patients. So we saw this as an opportunity to study patient acceptability of a social risk screening using a multi-domain tool endorsed by a federal agency. Our goal was to examine the acceptability of social risk screening to adult patients and adult caregivers of pediatric patients. We launched a mixed method study in 10 different clinical sites across the United States, including 4 family medicine, 2 internal medicine, 2 general emergency departments, and 2 pediatric emergency departments. The blue circles are the actual CMMI Accountable Health Community sites. The stars indicate our study sites, none of which were taking part in the AHC demonstration. We used fixed convergent methods, meaning it was a cross-sectional study in which the quantitative and qualitative data were collected at the same time with the intention of merging our findings. Each site recruited 100 English or Spanish-speaking patients or pediatric caregivers to complete a survey that included the CMMI 10-item screening tool, in addition to questions about their perspectives on screening. Additionally, each site was asked to conduct 5 interviews with a random subset of survey respondents. And today, I'll be focusing on the quantitative results, and Elena will present our qualitative findings and conclusions. We used 2 measures of acceptability in our surveys. 1, respondents' perspectives on the appropriateness of screening in healthcare settings, and 2, their comfort with that social risk screening information then being included in their electronic health record. We hypothesized that acceptability would vary based on several patient and healthcare setting characteristics, including prior exposure to social risk screening, trust, being surveyed in a safety net setting, and experience of discrimination within healthcare settings. This flow diagram shows that we approached close to 1,700 participants, 470 of whom declined to hear about the study, and almost 200 that didn't meet inclusion criteria. 1,037 started the survey and 1,005 completed it, and we conducted 50 interviews. The next 2 tables outline our participant demographics, separating out those who participated in both the survey and the interview, and those who did the survey only. We did find that more participants who reported lower income participated in the interviews. Otherwise, there were no significant differences between the 2 groups. And the second part of the table is showing responses to the social risk screening questions. And just for orientation, these are percentages in the 2 columns. What did we find? This graph shows participants' responses to the question asking, how appropriate is it to be screened for social risks at this healthcare setting? Responses from patients and caregivers recruited from emergency departments are on the top, and the second bar, responses from primary care, and the bottom is all of the respondents pooled together. We found that overall, about 80% of participants in both emergency department and primary care settings thought screening was appropriate. And recall that this first question we asked was, do respondents think it's appropriate to be screened at the setting where they were being surveyed at that moment? And our second question was asking participants about their comfort with social risk information being included in their electronic health record. And over 60% in both emergency departments and primary care settings reported being comfortable with EHR inclusion of their social risk data. To recap, a strong majority of participants thought screening was acceptable. 83% of primary care and 75% of emergency department respondents thought screening was very or somewhat appropriate. Only about 7% thought screening was inappropriate. And 66% of primary care and 62% of emergency department respondents were comfortable with screening information being included in their EHR. About 20% were uncomfortable with EHR integration of their screening results. We also explored what factors were associated with acceptability. These are the results from our multivariable model showing the adjusted odds ratios. Stars indicate a statistically significant result. Respondents who had previously experienced social risk screening, those who were being seen in a healthcare setting with higher numbers of publicly insured or uninsured patients, or who had higher trust in their clinicians, had higher odds of reporting that screening was appropriate. They had lower odds of reporting that screening was appropriate if they had experienced discrimination in the past. And only prior assistance with social risk factors within a healthcare setting was significantly associated with higher odds of feeling comfortable with EHR integration. The odds ratios on the last page should be interpreted with caution, as odds ratios can overestimate associations when the outcome of interest, in this case acceptability, is high. To put our results into perspective, this current figure and the one on the next slide show the predicted acceptability probabilities for the variables that were significantly associated with our measures of acceptability. And this current graph shows the probabilities of reporting that screening is appropriate. And you can see that although these factors were statistically significantly associated with differences in reporting that screening is appropriate, the differences were small and the ratios of the probabilities being on the order of 6 to 13%. So even among those who had prior experience of discrimination in a healthcare setting, or who had low trust in their clinicians, 70% or more reported that screening was appropriate. For comfort with EHR integration of social risk data, 63% who had never received assistance with a social risk factor from their healthcare setting versus 72% of those who had were comfortable with their social risk data being included in their EHR. We also asked all participants if they would be interested in any form of social assistance. 62% of respondents screened positive for at least one social risk factor, and of those, just over 50% reported they would be interested in receiving assistance from their healthcare team. 38% screened negative for all social risk factors. 10% of those nonetheless reported they would be interested in receiving assistance. These levels of interest in assistance are different from some prior research, where as few as 15% of those who screened positive indicated interest in assistance. An important source for this discordance may be that in this study, we asked about assistance in a hypothetical context. In summary, for our quantitative results, in this cross-sectional survey, including patients and caregivers from 10 different clinical sites around the US, respondents reported high levels of acceptability for social risk screening. And more respondents thought that screening was appropriate than were comfortable with their social risk data being included in their EHR. Factors like prior exposure to screening and trust slightly increased the appropriateness of screening, but experience of prior discrimination slightly decreased appropriateness of screening, whereas prior assistance with social risks from a healthcare setting slightly increased comfort with including social risk data in the EHR. I'm now going to pass it over to Elena to walk us through the qualitative results and our main conclusions and next steps. Thanks so much.
Hi, thanks, Amelia. I'm excited to kind of build off of everything we just learned from you in the quantitative survey results. And in doing so, I wanted to bring us back to where the literature and the evidence was on social risk screening when we began our talk. The knowledge at the time was really focused on single domain, single clinical sites in pediatrics, and we set out to get a broader scope of how patients felt about risk screening. And so what Amelia just presented is that patients found it acceptable across a multi-domain screener and in various healthcare settings. However, that left us with some questions in terms of what specifically made screening acceptable and how might we best meet the needs of patients who both find it acceptable and who also might have some concerns, particularly as enumerated in some of the EHR integration questions. So I'll cover the qualitative results from the study to answer these kind of remaining questions that we came up with. So first I wanted to kind of backtrack and talk about the methods for the qualitative data collection. Amelia touched base on the sampling frame and strategy of patients that were recruited to complete the surveys. In addition to completing the Accountable Health Communities screener and the complete study survey, patients were asked if they were interested in participating in a 30-minute qualitative interview. We selected 5 respondents from each interview site to participate in the survey, or in the qualitative interviews. Some sites were able to randomize, and so that 5 of the 10 were randomly selected. Some sites just selected 5 convenience representatives from those volunteers. All surveys were conducted in either English or Spanish, were audio transcribed and recorded, and then translated for us to code. The coding was done using basic thematic analysis and a constant comparative method. There were 2 coders that independently analyzed the transcripts line by line, generating common codes from the data to summarize key ideas. The codes were reevaluated, grouped into conceptual categories, and then we added a 3rd coder to adjudicate discrepancies and refine and harmonize codes into a cohesive coding scheme for all of the transcripts. The interview guide asked open-ended questions to understand how and why, or why not, patients felt that screening was acceptable. We asked specifically about emotional responses to survey questions, specifically kinds of questions like, how did you feel while answering the survey? Interviewees were given a laminated copy of the Accountable Health Community Screening Questionnaire to refer back to so that there was no confusion if we were asking them about the survey instrument versus the questionnaire with the social domain screening. We asked about specific experiences and context contributing to their responses. Have they seen similar questions before? Had they ever had help in any of these domains before? Were there additional domains that they would like to be asked about but weren't included on the screener? Those are some kinds of examples. And then we probed perspectives, asking what it was like answering the questions, where they would like to answer the questions, how it could be done better, differently, anything that they would change. And we collected all this data and arrived at 4 themes pertaining to the acceptability. Those themes were that participants believe screening for social risks is important. They expressed insight into the connections between social risks and overall health. Participants emphasized the importance of patient-centered implementation of social risk screening, but they recognized limits to the healthcare system's capacity to address or resolve their social risks. And so diving into some of these themes that we discovered. The first was that healthcare screening was seen as important to do. Participants expressed a sense of gratitude regarding the screening. They felt that they were grateful that people were finally asking them questions that pertain to their lives outside of the hospital. Per one quote, "It was a great survey to take. Actually, I'm glad I took it to see that somebody out there actually cares, you know." Another patient talked about how screening provided a complete picture, and the doctors could take better care of him and his family members by knowing things that were going on in his life. This quote says, "I think it's important for it to be in the chart because our medical providers then can, taking into consideration and looking at the entire person, not just the symptoms that are walking in." And so taken as a whole, patients were really happy that screening allowed them to express their social needs to their providers, but also that their providers were able to get a better sense of what their health could look like. That brings us to the second theme, which were connections between health and social risks. Patients were able to identify that stress and social risks were linked directly to health. One quote from a patient says, "Stress impacts health like crazy. Poverty and living at a survival level, whether it's your safety or finances or whatever, is massively stressful. I'm sure it just makes everything 10 times worse." Another code was aid in diagnosis. This is also related to knowing that social risk factors were predisposing certain patients and respondents to clinical conditions or medical issues that they felt their doctors might miss if their doctors didn't know about their social factors. And so this quote says, "So that my doctor knows why I have headaches, due to stress, because I have no place to live." Connections between food and health were also fairly common. The third theme was patient-centered implementation. This was feedback from patients about concerns that they had regarding the way that screening had been done in the past, regarding the way screening was currently being attempted, and how they felt it could be done in a better way to make them feel more comfortable. Respondents noted the importance of a compassionate approach. And this patient said, "I don't mind because if I feel like somebody is concerned, really concerned about me, I will answer the question. But I feel like there's somebody just asking me the question, just to be asking me because that's part of their job, I might not answer." There was a pervasive concept of not wanting social risk screening to be just another box to be checked by providers, and rather that it should come out of genuine empathy and true compassion for caring for a patient as a whole person. Privacy was another concern that was mentioned by a lot of patients. There was some concern that other people would know what was going on, or that doctors would share this information, or healthcare providers would share this information. And so here is one quote from a respondent. "The doctor can tell other people what's going on, but people talk, and you don't want your business spread around." The idea of privacy and compassion were also really interlinked. And so this quote, like with my first doctor I wouldn't have shared, came from a long monologue from a respondent who talked about how they had not trusted in their doctors in the past. They felt like their care was a lot of checking of boxes and not a lot of whole person listening, and talking about the fact that they wouldn't share unless there was compassion and empathy in the doctor-patient relationship, and how that would really facilitate responding in comfortable responses to social needs screening. The final theme was the limitation of healthcare to resolve the social risks that were identified. While patients felt that screening in a clinical environment was something that they were open to and thought was a good use of the healthcare team's time, they were well aware that their providers might not have the resources or time or bandwidth to address any sort of social need that they were asked about. This first quote is about understanding how clinicians are overburdened and overworked. And this patient said, "I don't know the way medicine is practiced right now. It could be whether it would, send doctors over the top. I mean, I just don't see there's time for it." So patients were aware that doctors were facing time pressures and that addressing social risks would add significant time to the visit. Additionally, patients did not see it as the primary responsibility of their healthcare team. But as far as the healthcare providers, I don't really see it as their responsibility. I think they should ask the questions, but I'm not sure that they should be responsible for helping solve them. And so taken in total, we were able to merge kind of the qualitative results, understanding what patients felt were concerns, how those concerns might be addressed, with some of the quantitative results to compare and contrast and come up with more complicated, nuanced interpretation. And so thinking about the complementary results, we have themes and quotes that allow us to reflect back on how to interpret the quantitative data. For example, as you may recall, 60% of the survey respondents thought EHR integration for their social risks was okay, leaving 40% did not think that they were comfortable with EHR integration. And so we were able to get a slightly more nuanced understanding of why people were uncomfortable with EHR integration. In their interviews, a recurrent theme was that patients were not comfortable with how their data could be used outside of the healthcare team. This patient stated, "I wouldn't want everyone to see what I went through. You don't want your business spread around." Since we did a concurrent design, we didn't have the survey results with us at the time of the interview, which would have enabled us to ask more targeted questions about survey responses or recruit more interviewees who thought screening wasn't acceptable. And so the implications of the qualitative findings show that taken together, screening is acceptable. Patients and caregivers see it as something important to do. It's directly relevant to their health. And when done in a patient-centered and empathic way, many noted that it could strengthen the patient-healthcare team relationship. But patients also saw limits to what the healthcare system could or should do. But regardless, they felt that screening had a place in a healthcare visit. So what does this mean for actually implementing social risk screening? Based on what we heard in interviews, there are implications for staff training and workflow in terms of ensuring a patient-centered approach. Outlying questions still exist regarding documentation, where and how it might be appropriate to include this in a patient's electronic medical record, and who on the healthcare team or outside the healthcare team should have access. There's also need to further evaluate how it should be integrated into routine care. Is it everyone, every time, all the time? Is it something that should be targeted for certain patients? In general, our interviewees felt like it was acceptable to be done as long as it was done in the right way with the right empathic implementation style. So thinking about next steps. Our hope is to use the same survey data to delve more deeply into predictors of patients' interest in assistance. We also want to use our qualitative data to better understand what patients want or expect from their healthcare system when a social risk factor is identified. This study also surfaced the experience of discrimination as an important predictor of these outcomes. If we were trying to increase the acceptability of social screening and of electronic health record integration, we need to unpack that finding and develop new strategies that address the concerns of these patients. Some limitations of our study. It is subject to response bias, as you saw earlier in the flow diagram. Not everyone who was approached agreed to participate, and it's possible that those who agreed to participate were more likely to agree that social screening was acceptable. This study was not designed to be comparative in nature, despite the fact that we included emergency departments and primary care clinics. We did not power the study to directly compare the responses between those two sites. And then there's a question about generalizability. We only recruited patients into our study who are either English or Spanish speakers, and we were limited as to other languages and people who could take part. So it's unclear if this is fully generalizable to the entire population. In conclusion, an important quote from one of the patients who said, "It was thought-provoking thinking about the situations that other people might be in, and maybe they're struggling and not able to talk to anybody about it. If you can't talk to your doctor about something, who can you tell? And so that just reiterated the fact that patients did feel comfortable sharing this personal information with their physician and care team. And so I want to thank all of the sites that participated in recruitment for patients where the study was done. And I'm going to leave some time for questions.
Great. Elena and Amelia, thank you so much for those presentations. That was great. And we have a whole lot of questions that have come in. So we're going to try to address as many of them as possible. First, I think some questions just kind of about understanding the study. So one person asked, are the primary care settings FQHCs or other kinds of primary care settings or both? Maybe Elena, Amelia, you can give a response to that.
Yeah, great question. So we had a mix of sites. We did, for eligibility for site participation, we did try to somewhat match some similarities between the actual demonstration project sites and our sites. So we asked that all sites have a minimum of 30% publicly insured or uninsured patients. And so we had some FQHCs or FQHC lookalikes, but then also some urban academic settings, some 2 rural practices. So it was a bit of a mix.
Great, thank you. And then what is the definition of prior healthcare discrimination? How exactly did you measure that?
Another great question. So we used the 7 questions that I think were initially published by Williams. I'm happy to send a reference that ask specifically about interactions within healthcare. So reading it asks basically, have any of these things happened to you because of your race, ethnicity, or socioeconomic status? And then they ask different questions about that you felt like someone wasn't listening to you or that you were treated with less respect. And then we combined all those responses to see if they had experienced any of those things within a healthcare setting. And it wasn't specific to the healthcare setting. They were currently being asked these questions.
Great. And there's a question here about who completed the screening. Was screening completed in the ED by an RN, a CMA, a CHW, a social worker? And do you have any data on whether or not trust differed by who administered the survey or the screening?
Great. Yeah, so we had trained research associates at all of the study sites. So this was a very much low touch intervention in terms of the healthcare activities at the site. So it was very much research oriented. So we had people recruiting participants from the waiting rooms at all of the sites. And they did know that this was a research study. So Trust was asking about providers at those settings, but we don't know anything about kind of their, it was all research staff, so we don't know anything beyond that. But Trust was very similar between all of the sites and regardless of what research associate was administering it.
Great. Then there's a question here about what were respondents told about who would have access to this information. So I think this relates probably in particular to these questions, I guess to all of the acceptability questions. Was there any preamble to explain where the information, how it was going to be used?
Yeah, we had a very lengthy consent, or not lengthy, but hopefully comprehensive consent that was administered either in English or Spanish, where participants were told that this was a research study, that all of their responses were confidential and nothing would actually go into their health record. Each site had to have a resource list of relevant local resources that they could give to anyone they approached, regardless of if they took part in the study or if they actually completed the survey. So the research assistant wouldn't actually know what a participant reported, nor would they know during the interview what someone's survey responses had been. The only exception was if they reported any level of verbal or physical abuse concern, in which case there was an alert that popped up for the research associate at the end of the survey. And each site had to have a site-specific protocol for who to alert. And at most sites, that after they saw the alert pop up, they would let the clinician know to screen for IPV on their own. And this was also noted in the consent that if there was any safety concern, they would have to notify someone at the site just for follow-up.
Thanks, Amelia. And then there was a quick follow-up question on the discrimination question. Did that include discrimination related to sexual orientation or gender identity?
I believe, unfortunately, the examples of what discrimination could be based on didn't specifically include gender identity, but it would be something that they could bring up. We had very few people. We did ask about gender identity as a demographic, and there were not differences in terms of acceptability based on that, but the discrimination didn't specifically call that out in like the examples.
Great. Then there was a couple of questions that have come in about, did you have any way of measuring how truthful people were in their responses to the screening questions? I think this might be particularly around, when they're responding about their needs, but it could apply, I guess, to any part of the survey. Did you have any way of gauging that?
Not specifically. So we had no way to verify or like gold standards to compare to, but participants could skip any questions that they wanted to. And it was obviously voluntary to participate. So this is obviously a limitation in terms of selection bias for the study. But we had very few people skip questions, and no one skipped all 10 of the screening questions.
Great. Did you have a question about health literacy? And if so, did it have any relationship to acceptability?
Another great question. We did not have space to also assess health literacy. We did ask a very comprehensive question on self-reported education that went through all the different grade levels, and we intentionally made sure that our survey questions matched the reading level of the Accountable Health Community Screening Tool itself, and that tool is at a 9th grade reading level. And so we did assess what percentage of our population reported completing less than 9th grade, which was about less than 7% of our patient population. And we did, because the surveys were self-complete, one of the eligibility criteria was that the participant could complete it on their own. And very few people, as noted in the flow diagram, were not able to complete the survey after they started it.
Great. So many great questions. Thanks for the quick responses. There's a question here about whether there were data collected on interviewer demographics, drug users, patients with past psychiatric needs. And then also maybe you can mention a little bit about just the general demographics that were captured and if there were any differences in acceptability based on that.
Yeah, great question. I can even go back to our demographics slide at the very beginning, I think. Yes. So we did not ask specifically about substance use or mental health questions. We did ask general demographics about gender identity, self-reported income and dependency, which allowed us to calculate the FPL, language preference, educational attainment, race, ethnicity, and these were not significantly associated with acceptability in our models. And we were surprised by this, but because I think acceptability was so high throughout, we didn't capture any differences based on patient demographics.
And did you see any differences between rural and urban sites?
We did not. That being said, I believe only 2 of our sites were rural. So much smaller numbers, but we did not see any differences.
Great. And there was also a question about whether there were any differences from pediatric sites versus adult sites, either in the qualitative or quantitative data.
Yeah, we had 2 pediatric emergency departments, so those were primarily all caregivers of pediatric patients who were responding to those surveys. We did not see differences between those 2 sites and the other sites, which were a bit of a mix, but there were not differences in terms of.
And
yeah.
Elena, did you look? You have obviously a totally different sample size. Did you look at all at any differences between sites or no?
Yeah, so because it was a qualitative, it wasn't meant to be comparative. It was just meant to look at themes across sites. So we didn't do the analysis by site. We just kind of pulled it all together to look for cohesive themes.
Yeah. Now, there's a question here, I think, that goes a little bit to this question of response bias and generalizability. So you had a relatively high proportion of people that you screened who did not want to participate, I think close to 30%. Any idea why so many people didn't want to participate, and what impact do you think that might have had on the results? Do you think that you have a really selected group of people who are more likely to find it to be acceptable? Do you have any way to know that?
Great question, and always hard to verify, and a huge limitation of any survey work. I should point out that among those who declined to participate, so like 470, only 28 of those had actually heard about the study before they declined. So the vast majority had actually they were approached in the waiting room and they said, no, I don't want to hear about any study. They didn't know what the context of the study was. The research assistant just approached them and said, we're conducting a survey study here today. Would you be interested in hearing more about it? But obviously, there can be differences in terms of who is willing to and has the time to actually participate in a survey with busy schedules. And so there's always a possibility for response bias as a limitation.
Yeah, I found it interesting that the folks that were willing to do the interviews after filling out the survey were actually more likely to be poorer. And I wonder if that's also true overall, that the people that were willing to do the survey compared to just all the patients that might have been approached might also be lower income. I don't know if that's related to maybe you're not working and you have more time. I don't know. But I agree that's an interesting and hard to answer question. What about the question of why people may not want assistance? Any thoughts about that? Why do you think so many people were not interested in receiving assistance?
That's a great question, and I think one that is of high interest, given that a number of studies are coming out now showing that there is a bit of a drop-off of people who will disclose a risk but then say that they don't want assistance with it from their healthcare setting. And Elena can mention some of the qualitative findings, but I think there are a number of reasons why this might be happening, whether they're getting assistance elsewhere or they don't actually perceive that they have a need for assistance at that time. But I want to give Elena an opportunity to answer this too.
So it really kind of runs the gamut as to reasons why respondents would screen positive but not ask for assistance. There's definitely a component of, well, I screen positive because, yes, this is true. For instance, I do run out of food every month, but I don't need assistance because I already go to the food bank. So despite the fact that I can't afford any more food, I already know how to solve the problem. There are also kind of time lag concerns because some of the questions ask about things in a time frame. So if this could have been true last month, but this month you're not worried, and therefore this month you don't need assistance. Whereas if you had asked me the same question last month, not only would I have screened positive, but I also would be asking for assistance. It also kind of cuts the other way. We definitely saw respondents talking about how they themselves didn't need assistance, but would like information or like referrals because they had family members or friends that they knew were facing these kinds of social needs and would like to pass on that information. And so, yeah, I think there's a lot more space to explore the divergence of, screening positive or not, and then asking for assistance or not.
Great. And then Elena, it sounds like in the qualitative study you asked people how they would like to be asked these questions. What did you hear about that? Did they give you any information about who they would prefer to have asking the questions and kind of in what context?
Yeah, so that's actually a really interesting question. And so there were a couple of different takeaways from the who, what, when, where, how kind of series of questions that we asked in the interviews. The overarching theme is that there was literally no agreement. Everyone had something different. Someone wanted an iPad screen, someone wanted a paper screen, someone wanted to be asked these questions because of literacy and language-based issues. And so there was really no overarching, this is the implementation strategy for how best to do it. In terms of the who, a lot of people talked about their healthcare team, and it was really unclear who kind of fell within the rubric of the healthcare team and who fell outside the rubric of the healthcare team. Some respondents were very clear that doctors and nurses were the people that they wanted. Some people were a little bit more ambivalent as long as it was done by someone who worked for the healthcare setting. And some respondents were pretty clear that they felt that the social worker was external to the healthcare team and had some concerns about the social worker communication with the healthcare team and what would be considered private and what wasn't. And so it really ran the gamut in terms of what the responses were as to who the right person would be, which is why you didn't see a cohesive theme about, this is the right person and this is the right way. Because there was just such a wide variation in what people said and what they felt.
So interesting. And then somebody wrote in a comment that I wonder if you comment on. It says, it seems as though you shouldn't screen about these things unless the provider can address the needs with a specific referral. Do you feel like the data you collected sheds light on that, whether or not you should only screen if you can provide a referral or if it would be potentially good to screen just to have that information?
Yeah, it's a great question. I think that's one of the really big takeaways of this study, that by asking patients what they felt, we can really say with confidence that all patients should be screened regardless if you can offer assistance or referral or not. Patients saw value in the screening process regardless of having their needs met or regardless of assistance being available. They felt that by being screened as part of a healthcare visit, it improved their relationship with their physician because it allowed their healthcare provider, whether it's a physician, nurse practitioner, physician assistant, see them as a whole person and understand the whole spectrum of obstacles in the way of good health. And it also felt like it allowed them to kind of express themselves in a more free way, and that it was not contingent on getting help specifically, but rather kind of opening up lines of communication between the respondents and the healthcare provider.
That's super interesting. Okay, and somebody said that we didn't quite fully answer the demographic question. So they're specifically interested in understanding were there gender differences or sex differences between an acceptability to social screening? I think Amelia, that
I
one's for you.
apologize. I answered directly to him. We did not have differences by gender, but
Okay.
Elena is actually leading an analysis really just focused on gender differences, but in terms of the acceptability, no differences.
Great. And then were there any differences, I don't know if you guys have done these analyses yet, were there any differences in those who wanted follow-up after positive screening? Any demographic differences or any other things that relate to whether or not people wanted follow-up?
Another great question. We're actually in the midst of further analyzing that data. In some early analyses, we're seeing that people who were reporting more than 3 social risk factors versus just versus 1 or 2 who reported getting assistance with from healthcare staff in the past, lower income, Spanish speaker, non-Hispanic, Black reported race ethnicity, had some higher odds of reporting assistance, but we're in the midst, so those findings may change.
Great. One of the participants is asking, the social determinants of health term is one that, can sound very researchy or abstract to folks, or not quite. Some people sometimes have concerns about using the word determinants because it makes it sound like there's nothing you can do about it. Did you, through this work, and I'm thinking maybe the qualitative work in particular, did you feel like you came away with any conclusions about the best terms to use to describe what we're trying to screen for here?
I think it's a great question. I know in the literature and kind of the way it's being talked about as the implementation of these individual domains is being referred more to health-related social needs, and so not like moving away from social determinants of health and thinking about them in social needs in terms of thinking about like what the providers and the clinics are offering and doing. In terms of asking specifically to the respondents how they felt we should best kind of group all of these ideas together, we didn't really come across any sort of cohesive like, oh, I would call this, my social risks. I would say it's more kind of on the provider research side, how we're really distinguishing social determinants of health and like healthcare-related social needs. But on the respondent side, there was kind of less clarity about the right words to use.
Great. Then there's a bigger picture question here, which is any thoughts on how collecting this data can inform public policy and social services? It's a big question, but curious what your thoughts are after doing this work.
Well, I mean, I thought in particular the richness of like the qualitative data kind of spoke to a lot of the concerns that are being bandied about by other researchers in terms of like the ethics and the responsibility on the provider side of what should or should not be done. And so I think there's a lot of hesitancy on both the provider side and on the policy side to really mandate that this is something that should be done, that this should be considered part of like healthcare and wellness. Because there's concern, as one of the questions was, that if we can't address this, is it really screening? And what is screening for if you can't intervene? And I think some of the richness of our data really lets us know that there's value here despite not having, a box-checking solution to address these needs as soon as we identify them. But rather it gives providers a better opportunity to take whole person care of their patients. And our respondents, the patients and the caregivers to pediatric patients, really made that clear that they saw the value in their providers seeing them as a whole person, understanding the stresses in their lives, and how those stresses can kind of help them get better care.
There are a couple of questions here that relate to this idea that, respondents in the qualitative data very much appreciated being asked this, but also understood that their providers maybe weren't the folks that were going to be able to help them with these issues. Did you hear folks talk about wanting referrals to outside agencies, or did you hear anything that could help inform then what ideally healthcare settings could be most effectively doing besides just asking the information because that makes patients potentially feel better cared for, but on the side of helping address needs? What did you hear that you thought?
Yeah, I mean, we heard a variety of things. Like, again, as much as I kind of wish there was like a, let's nail down the answer and everyone should be doing exactly this. We didn't find that, but there was a lot of support for the kinds of things that I know already exist kind of out in the landscape. So there was a lot of endorsement for referral sheets, like just a list of available resources in the community. We definitely had some respondents who were very receptive to the idea of patient-facing literature. For example, stating things like we're waiting in the waiting room, and if there were just brochures and signs saying like, this is all here for you, here are the food banks, here are the housing resources, here are phone numbers to call, here are local kind of legal aid services, it would let us know that it was more than just a question, but also your entire practice was kind of invested in thinking about this and helping us move forward. There were some discussions about warm handoffs as opposed to just a cold referral. Like some of the more savvy respondents who had experience with being screened before and with being referred prior knew the difference between when someone from the health system picks up the phone and speaks directly to a social service agency versus being handed a phone number. They were able to talk about how valuable that warm handoff was. And so while we didn't have a one right answer for how best this should be done, I think the patients and caregivers that we interviewed saw what was being done and felt that it was a good first step.
Mm-hmm. That's helpful. And then one last question I think we have time for, which is around if you have any suggestions for how to address the privacy concerns expressed by some. I know you highlighted a few things in your presentation, Elena, but maybe you can speak to that a little bit more. And the speaker specifically says, should there be a box around social needs info as is the case with mental health, HIV, et cetera?
Yeah, it's hard. So this is one of those cases where the qualitative data allowed us to really see that there was maybe not a quite comprehensive understanding of who actually has access to your electronic health record, and the fact that your electronic health record data is actually not publicly available to every person in the clinic at all times, and people, or patients or visitors to the clinic. And so the privacy question, I think, is a real implementation question, because some of the privacy concerns were related to the electronic health record and where the data is stored. But some of it was just in terms of, like, I don't want someone reading over my shoulder if I'm answering this iPad question, or I don't want anyone listening to me respond if the medical assistant is asking me these questions in the waiting room, or if the check-in person at my clinic is asking me these questions. And so I think, there needs to be a little bit more research done to figure out in terms of how best implementation practices move forward and like what privacy means in different domains. So for instance, what the electronic health record privacy would mean, would it just be providers like nurses, doctors, and social workers who have access to it, versus like the whole healthcare team is okay as long as it's not people from the waiting room who can see it, and then also just the actual implementation of screening so it can be done alone in a safe space where you don't have the concern that the person sitting next to you in the ER waiting room can see your responses.
Great. Well, thank you, Elena. For any questions that we haven't answered, please feel free to reach out to Elena and Amelia directly. As we close, I want to thank our two speakers. That was really interesting. Thank you so much for sharing those findings. The slides and the webinar are going to be posted on our website, and all of you will get an email with that. I want to highlight that we do have another webinar coming up in a month on the validity of clinical social risk screening tools. And the link to that is on this slide. You can also find it in our newsletter that went out this morning and on our website. And then finally, please tell us what you thought about this survey by filling out, about this webinar by filling out this survey. We really, really appreciate the feedback, and it'll help us make future webinars better. Thank you again all so much, and I hope everybody has a good rest of their day.